Meeting is called to order. If everyone would rise with me for a Pledge of Allegiance. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Catherine, would you take the roll call, please?
Director Danielson.
Present.
Director Nicholson.
Present.
Director Stewart. Director Epen.
Present.
And Director Wallace will not be here.
Thank you. Thank you. Next item on our agenda is a educational session. Nancy, could you please do the introductions?
Yes, I'm very pleased and proud to introduce Mintu Denon. She's appeared before the board before. I want to remind you of her background and her wonderful qualifications. She completed her undergraduate work at UC San Diego and received her doctorate degree in pharmacy at UC San Francisco in 1989. After graduation, she began her career at the Naval Medical Center in San Diego as a clinical pharmacist specializing in infectious disease. And that background could not be more important to us with today's challenges. After a couple of years, she continued working closely with the infectious disease department, involving herself in clinical research with several local and national presentations and publications. She also assumed the role of clinical coordinator for the PharmD students program and other clinical pharmacy services. She began her career at Washington Hospital Healthcare System in 1995. She started as clinical pharmacy specialist, and later she assumed her current role as director of the pharmacy just 4 years later in 1999. So I'm very pleased to have Mintu come before the board and make a presentation on our Medicare system.
Great. Thank you.
Good evening. I've been asked to come today and provide you a update on the Medicare project. So through this presentation, what I'm hoping to do is to demonstrate the impact of the Medicare project on improving patient safety within the hospital and also increase efficiency within the pharmacy. I will take the opportunity to create a common understanding on how the Medicare project is related to the IV room project, in which you just approved, not recently, which will allow us to be compliant with the U.S. Pharmacopoeia national guidelines on sterile IV admixture. The first big challenge that we had was how to increase the square footage to increase the size of IV room while maintaining the current storage of pharmaceuticals that we have within the pharmacy, because the walls within pharmacy were not going to move. After multiple tries, I finally concluded that the walls weren't going to move. And that leads us into what is the Medicare cell. The Medicare cell is a vertical, high-density, space-efficient, automated storage and retrieval system for medications in the pharmacy. I started looking at this because I needed to move the medication into a space that's going to be much more efficiently used in the current space that we have today. So if you look at it, it's 27 rotating shelves, and it rotates vertically. Each shelves hold a maximum of 29 bins. Each bin store a maximum of 4 medications in depth. And the storage capacity, it will store almost 3,000 medications. And that's a picture of it. Some of the additional features that came along with this high-density storage unit is that it has a pick-to-light technology. And what that means is that the platform in front of the Medicare cell, it will light up. The areas will light up where the medication is stored. So it will guide one to which bin to pick the medications out of. So it guides us to the correct medication storage. It forces compliance also with barcode scanning process. So every medication in the Medicare cell is barcoded. You can't remove and you can't add any medications to the Medicare cell unless you scan the barcode, which serve as a double check systems that we have in place. So it prevents medication confusion. It allows us to segregate the look-alike, sound-alike, the high-risk medications into separate bins. And if you notice, there's red bins and there's blue bins. The red bins is what we use to store the high-risk medications or the medications that are look-alike or sound-alike. This is what the pharmacy looks like prior to implementation. If you notice, there's shelves, there's static shelves, and you have to move the shelves and walk down the shelves in order to get the medications you need. On the right-hand side is post-implementation, and if you notice, the bins are very closely aligned, and allow us to maximize the space that's needed. So if you look at the dimensions, you notice that the mid-carousel will take it's half the dimensions of the static shelves in depth and width. The other thing too is we're able to utilize the height. So the mid-carousel, they can build up to as high as your ceiling will go, and it will go into the ceiling if the opening is if there's nothing above it. So our timeline, we initiated the project in October 6th of 2010, the end of last year. We had a site renovation in January. In February, we had the installation of the mid-carousel. In March, we did integration testing. In April, we had occupied out and certified the space as usable and allow us to move forward with the implementation. On the April 17th, we did training within the pharmacy department and for the help desk. On the 19th, we went live. And when we went live, we decided to go live comprehensively, which means every single medication leaving the pharmacy and every medication coming into the pharmacy will be barcoded, and we will use barcode throughout the whole process. We had ISMP site visits in May of 17th, and we showed them the mid-carousel, and they liked what we had done there. And on May 20th, we start our optimization project, and I'll talk a little bit about optimization later and how we can use the system. So as far as process efficiency, if you look at the medication use process, it really boils down to 5 main steps. There's a prescribing phase where the physician writes the order, and within the pharmacy, there's a purchasing, inventory control, and dispensing within the pharmacy. And at bedside, there's administration at bedside. And Epic will addresses the prescribing phase, and they will address the administration phase with the barcode at the bedside. But they don't really have anything for the in-between part. So that's where the mid-carousel comes in. It's the bridge between the beginning and the end product. So what does it do? I'm going to go through each one of the steps a little bit more carefully. It automates the ordering and the inventory control. And what that does is it reduces steps and increase efficiency or accuracy. In ordering and inventory control, what we used to have to do is we used to have to walk the shelves to see, okay, what are we running low on? And then we go through the whole ordering process, we write down the want book, and then we order the product. Now, after the implementation, we are able to automate that step. So for each one of the medications, we put a min and max level of how much medications we want to keep in stock. And then the mid-carousel will automatically generate an order based on usage and downloads the order automatically at the end of the day, and it submits acknowledge the order. So therefore, it really keeps track of what inventory you have on hand through this process. It automates the whole ordering process for us. And as far as dispensing and restocking, before the process would be the physician writes the order gets scanned down to the pharmacy, the pharmacist will enter the order, and then releases the medication in the sense that, you know, the medication is stored on the Pyxis machines, on the med stations on the unit. It releases the medication so that the nurse can retrieve the medication. Or if the medication is in the pharmacy, the techs will then walk the shelves, pick up the medications, and have the pharmacist check it and deliver it. So that's the manual process before implementation. Post-implementation, it's the same process holds at the beginning. The physician writes the order gets scanned down to the pharmacist enter the order. But now, instead of the techs walking the shelf to try to find a medication, and hopefully it's there, the mid-carousel will rotate to where the medication is stored at. There's really only one level where you will pull that medication. It rotates to that level. The lights will point you to where the medication is stored at, and since it's 4 deep, it will point you to which level the medication is stored at, whether it's first, second, third, or fourth, the depth of the bin, and then that's the medication you take out. You have to scan it now to double check to make sure that it was the right medication, it was in the bin, so you scan to make sure. So there's multiple steps along the process where there's double checking systems in place now. Let me take a step back a little bit, because before you can go on with the scanning and all that, which is not directly part of the project, but we have to get our medications to have barcodes on them in order for this to work. So one of the other things that we had to do is we did a readiness assessment. In our inventory, we have over 3,000 line items, and about 3.5 million doses are dispensed a year. So when we first started looking at the medications, we noticed that about 86% of the doses are barcoded. There is a barcode on them. The other 14% or so does not have a barcode on it. So we have to come up with a system to get barcodes on the other 14% of the doses, which equates out to be about 500,000 doses, 500,000 doses a year. One of the things we had to do was we had to update our software. The pre-packaging software we had did not allow us to print out a barcode, so we upgraded our software to allow us to barcode these medications. So in moving forward towards barcoding, we now can use the barcode for inventory control. It increased our accuracy. It decreased human errors in picking the wrong medication. It increases the use of automatic data collection through the new systems that we have implemented and using the barcode. It gives us timely feedback in the sense that real time, we can capture data real time. How much drugs we have on inventory, how much of each dose we have in inventory. We track expiration dates for all those medications. So we know at any one point in time which medications we're going to have expiring first, and we need to rotate those the stock better. Improve efficiency. The manual activities of walking the shelves and picking the medications and ordering the medications, we eliminate that. Now we automate that step. So as the end results, it ensure accuracy on purchasing, dispensing, and administration really throughout the use by using the barcode. Some of the success measures, because that's one of the things that we always ask for. How do we know that we're doing better? And these are just some examples of some of the reports that we can get from the system, some of the things that we're monitoring. As far as picking errors, we know that we had picking errors before. The text picks the medication, the pharmacist double checks. So, the doses are very small, the font's really small, and so we have decreased our picking errors in a sense now. It's barcoded. It's barcode before it goes into the carousel, requiring to scan the medication. When you remove the medication, it requires the barcode. You can't bypass that step. So as far as picking errors is concerned, we can ensure that our picking errors have decreased. The time that daily takes us to create an order, send off an order, it takes us about 2 hours a day to really walk the shelf, making sure we have, we're not running out of stock on anything. Now that whole process is automated. So twice a day we run the report and we send off the our orders. Some of the other preliminary results is decreasing time to inventory. Before, we used to spend about 40 hours or so once a year to prepare for inventory and have an outside company come in and do our inventory. And now, we can automate that. We can run the report anytime and know what our inventory is within the pharmacy. And then we would run a different report to know what our inventory is in the med station. So as far as inventory time, it significantly decreased our inventory time. And we actually confirmed this in June when we did our end of the year inventory. On the June 30th, we have an outside vendors that come in and count for us every medication that we have in stock. So we actually confirm the reports that we run from the system and the reports that we run that we obtain from the outside vendors, and the dollar amount very closely match. So we've confirmed it this year. That actually works. Here's one of the reports I really personally like, because the graph looks a little bit complicated, but let me go through and explain this. There are, like I said, 27 shelves. So that hence 0 to 27 shelves. And the concept behind this is shelf 1 to 9 is where you store your fast movers or the medications that you use most often, because you don't want the shelves to rotate very much, because that's how you increase efficiency, is not having the shelves rotate so far to get your medications. So the medications that move often, you want to keep between the shelves 1 through 9. And then 10 through 18 is your medium use medications. And then the 20 to 27 are your slow movers, or the ones that you don't use very much. And you store those really high up so it doesn't have to rotate very often. So ideally, what you want is 1 through 9 to be all green, 10 through 19 to be all yellow, and then 20 to 27 to be all red. We organize the shelves based on last year's usage data. And as you know, over the years, your usage of certain medications will change as therapy change and practice guidelines change. So by running this on a quarterly basis, you can tell whether your medications are stored at the right location or not, based on constant use of that medication. So this is what I'm talking about when I'm talking about med carousel optimization, is you want to minimize the time that takes you to pull that medication, and you want to optimize the use of the med carousel, and look at your slow movers and make sure you don't have those sitting on the shelf too long and expiring on you. And so this is just a good example of that. So in summary, we started out with looking for a high-density storage unit to better use the limited space we have. And in the end, what we found is that not only do we have that, we also improve our inventory control. We can track perpetual inventory, reduce stockouts of medications. So we have medications more readily for use for patient care. It increased our productivity because from a workload efficiency standpoint, it not only reduced staff training time, it really minimized the different locations they have to go to pull the medications, because now the medications come directly to them, and all they have to do is just stand in front of the med carousel, and the medication will come to them. It will point to where they're supposed to be, getting the medications, and it's easy for new staff to figure out where the medications are stored within the pharmacy. So beyond the storage and inventory management control, it also enhanced patient safety through the use of barcode, because now it's barcode driven. You can't load the medication into the machines without scanning it to make sure that, because when you scan the medication, the system will rotate to the right spot and tell you exactly where to put it in. And you have to scan the medication when you bring it out, and it reduces picking errors. So in the end, it really is, enhancing patient safety. Thank you. And I'd like to make one acknowledgement. There's somebody that I really want to acknowledge, because I think of the project and I really turn it over to have somebody else implement, which is a nice thing. And I just want to acknowledge Jenny Nguyen, who's the pharmacy operation manager. Jenny, stand up. She's actually the person really behind the work of the med carousel and make it really successful. And I just want to say thank you.
Thank you, Min. I find this fascinating because many years ago, I was in the same situation, and I was a beginning clerk in the medical record department, and we used the same kind of a system for the storage of our patient index cards. But never in my wildest dreams did I think that it could be used for anything else but that. And of course, what you've got is more sophisticated, but that's an excellent solution to a storage problem. Excellent, and good quality control, too.
Thank you.
Great. Any other board members have a comment?
Yeah, no, it's a great system, I agree, but what's the cost on this?
Let me answer it this way, Dr. Eapen. What would it cost to build a new pharmacy?
Right, yeah.
And you did this instead of that. And you gave life to a facility that serves many more patients than the pharmacy did when it was originally designed. And it gives us a few more years before we can have our new hospital building, where we'll have a new pharmacy. And we get very inventive about how to make 10 pounds fit in a 5-pound sack. So every penny we spent on it was worthwhile in terms of that. I think the step forward that we make in patient safety and reducing medication errors is priceless.
Absolutely, yeah. But what I'm saying is there's definitely a price on it.
Absolutely. Ed?
It was about, as a total project, it was around $350,000.
It's a bargain.
Yeah, it's not bad.
Yeah.
I have some questions for Min, too. The med carousel, you said, has space for about 3,000 medications, and you said the pharmacy stocks about 3,000 line items. Does that mean the med carousel is full, or how much reserve space do we have? Because we know there are new medications coming out, it seems like every other day.
There's no
So
research.
storage units of 3,000 medications, if you use the smallest bin and you maximize all four as for 4 different medications. And as you know, if you have the little small tablets, that would work. But when you start dealing with the inhalers, the liquids and stuff like that, we actually take up several bins for our fast-moving items. So it stores about 60% of our medications that we have. So we still
Okay.
have some others that's on the shelf.
We've got a lot of room left for
because-
expansion. That's always good.
Absolutely. And we really maximally use that, our carousel. One of the graphs, let me see. Actually, one of the graphs shows you the percentage this graph right here.
Uh-huh.
So the recommendation is for you to leave a little bit sort of wiggle room to move the bins around. So that's the white bars at the top. So you want to be at about 90%, which means you maximally use every single one of the shelves. And if you notice, there's not much white bars up top at all.
Right. Another question, you talked about expiration dates. Do the barcodes themselves encode expiration dates, or does that have to be physically looked at when medications are dispensed?
It has to be physically looked at.
Okay,
So
so-
when we add medications back into the Medcarousel, we look at the earliest expiration date. The earliest expiration date will appear on screen, and you look what you have in your hand, and that expiration date is earlier than what it says, then you change the date.
So when somebody goes to the med carousel to pick, they'll not only pick the medication, but they'll look for a particular expiration date as well, so that your inventory system is...
Actually, everything that's in the Medcarousel, you know have not expired.
Okay.
So they have to look there. What they have to look at is when they add things to Medcarousel.
Okay.
To make sure that what they have in their hand is not earlier than what it says on screen.
All right, okay. The other question I had is, it was very interesting for me to see that the med carousel was not just this big piece of hardware, but actually a software inventory control system. And I'm wondering if the med carousel system can actually give you information on change in medication use pattern. The reason I'm asking this is if we're having, every physician in the hospital does their own thing, and not everybody is seeing what other physicians are doing, what other diseases might be cropping up. So the pharmacy is kind of one final common pathway where a lot of that prescribing data goes through, and if we're seeing a particular disease state or something of that nature rise up, I would think the pharmacy might be one of the first places we might be able to visualize that or understand it. Do we have that kind of system within Medicarousel to look at change in medication use patterns over time?
Well, we can use this for tracking sort of the usage. It's not going to be broken down specifically to disease states or physician specific or anything like that.
Right.
But yes, this is an inventory, so you can look at the change inventory, and you can look at where your low movers are, and if they start moving to like yellows and red and greens, then you know it's being used much more often.
So you can look for a shift in the usage
Right.
pattern? Okay,
Right.
good.
Good question. Any more questions? No. Comments? Thank you. Thank you, man. Good news.
It is foreseeable that in future years we'll ask for a second
Of course.
med carousel.
Yeah.
This has been a resounding
Where are we going to
success.
put it?
Well, you saw where the movable shelves were?
Yeah.
Those can leave.
Okay.
And she said she could go up into the ceiling if it's empty up
I'm
there.
sure I'm sure it's not empty up there.
No, it's not empty up there. Darn.
Okay, our next item is, ICD-10.
Oh, this you're going to
And I
love.
say that with pain.
Now, ICD-10 is a new coding system for health information. And it's my pleasure tonight to introduce the board to Wanda Zimba. And she passed her first anniversary at Washington Hospital yesterday. And we are very fortunate to have her here. She is an extremely accomplished health information and compliance specialist. And I want to tell you a little bit about her. She's been involved in healthcare coding compliance for over 30 years. And she is our coding compliance manager in our health information management services. In this position, she's primarily responsible for coder training and assurance of correct code assignments, and is also an active member of the Compliance Committee, our RAC Oversight Committee, Revenue Integrity Task Force. She works with the 5 Million Lives CHF and AMI work group, and she is also the ICD-10 educator for Washington Hospital. Prior to her hire here, she was the Associate Compliance Officer for the UCSF Clinical Enterprise. Prior to that appointment, she was Director of the Health Information Program at Chabot College, managing a successful consulting firm, and was also the CCS Liaison Professional Fee Advisor for Children's Hospital Oakland Research Institute. She graduated from Concord Law School in December of 2010, receiving the Executive Juris Doctor in Health Law and the prestigious Sue Lane Award for pursuit of academic excellence. Extensive legal training in healthcare issues, including health law, bioethics, malpractice, health policy, auditing, monitoring, and risk assessment, as well as experience serving as liaison between all management levels across multiple organizational functions and between healthcare organizations and regulatory bodies, provide her a sound foundation for negotiating complex healthcare delivery and reimbursement issues. She received her MFA from California College of the Arts and her Bachelor of Arts from Vassar College. She currently holds certification as a registered health information technician, certified in healthcare compliance, certified healthcare compliance officer and consultant, certified professional coder, and is an AHIMA certified ICD-10 CM and ICD-10 PCS instructor. She's a first-year director on the California Health Information Association Board of Directors, a conference educator, and a professional speaker.
Thank you very much for that introduction and for the opportunity to address the Board of Directors. I'm very pleased to be here tonight. Healthcare professionals across the country have been preparing for the transition to I-10 now for several years, some of them with a great deal of dread, others with a lot of anticipation. The change is predicted to be more complex and more costly than the changes that we associated with Y2K. It's very complex, primarily because it affects everyone. It's going to require champions at all levels, from the clinical providers to the medical records folks to the individuals in finance who deal with our coding and reimbursement. And because it affects everyone, this is going to be vitally, vitally important. On October 1st, 2013, we will transition from ICD-9, a coding system that has been in use for many, many years, to ICD-10. And this evening, I'm happy to provide you with a brief overview of what this means, some of the history of this particular system, and what we're doing here at Washington Hospital in order to assure that we transition into it effectively and efficiently, and we support our providers, our clinical providers, in being able to manage the transition in their offices. I personally am very excited about this transition to I-10, as well as a number of my colleagues. We've all had the opportunity to be working in I-10 for several years, and I can tell you that it's a very, very robust program. It's much more than just the ICD-9 all grown up. It's something that's going to provide us with much more effective data and a greater ability to achieve fair reimbursement in a timely manner. So we'll be looking a little at the history and the rationale and some of the differences between I-9 and I-10. It is federally mandated. We don't get to put it off. It isn't something that's affecting only hospitals. It affects everyone. It's something we're all going to have to do. Now, just a little bit, we use a number of coding systems in healthcare. Some of them are primarily for reporting clinical activity, as well as reporting statistics to the state. Some of the coding is for billing activity, and there are some code systems that effectively work for both. ICD-9 is one of those. ICD-10 is one of those systems that works for both clinical activity as well as reimbursement. The ICD-9, which we currently use, is the International Classification of Diseases 9th Clinical Modification. This coding system is used to report the reasons why a patient would present for healthcare services, and the PCS portion of it is used by hospitals to report those services that are provided to inpatients, and it's used to communicate the resources necessary for the hospital to expend in order to provide the best possible care for those patients. The ICD-9, as we know it, has been in use since 1979, and although we get annual updates, they really fail to keep up with medical technology. And this is one of the reasons why we now have I-10 on our horizon. But in fact, ICD-9, as we know it, goes back even much further than that. It goes back to 1891 to Jacques Bertillon, who developed this system called the Bertillon Classification of Causes of Death. So it's really been around a lot longer than that. Much of the ICD-10 is very similar to ICD-9. Some of the rules and regulations that we use for assigning these codes are identical, but the codes look dramatically different. My coders all memorize their codes. They know them by heart, and many coders do that. They're going to have to sort of retool themselves and think about these 7-digit codes now instead of the old 5-digit codes. The ICD-10, though, has been in production for a number of years, and I can say that probably around 1993 was when we first saw some of the beginnings of the very robust I-10 system. It was developed and used primarily in Canada, and they call it there the ICD-10-CA for Canadian, and they do not use the Volume 3, the procedure coding system, because their reimbursement structure is very different from ours. One of the things I think is very important to emphasize is that this major change does not affect CPT, current procedural terminology. You can see from the chart that I have on the screen that CPT, or HCPCS, are used predominantly by physician practices to report their professional fees. This system is not affected by this major change. CPT is also used by hospital outpatient departments to communicate those resources associated with short-stay surgery, outpatient services, reoccurring services. The only change that physicians will appreciate is some increased or more detailed documentation that will be required so that they can effectively use the I-10 system to the level of granularity that it was designed to be used. So why is this necessary? Why is this change actually happening? The old system simply has not kept up with the changes in medical technology. It's very, very outdated. There's little room for expansion. The diagnoses are no longer accurate. One of the difficulties with the little room for expansion is we find that codes that should belong together are scattered throughout the entire book because there's no room for them in the chapter that they should belong. So coders have to spend time moving around into different chapters to get the most precise coding that's possible. The family groupings of diseases are now obsolete, according to our new medical advances. The continuum diseases that we have is not adequately measured, or it's not adequately communicated. One of the great examples that I like is that if you fracture a bone and then you have a problem with the healing of that bone, you have a malunion or a non-union or a delayed healing process, those codes are located somewhere else in the book. They're not located where the fracture codes are. So in the new system, you will have codes that will give you information about that continuum of care from the initial treatment of the fracture all the way out to any sequela that may develop from that fracture itself. But primarily, this whole assignment of these new codes will give us an opportunity to use data in a way that we have never been able to use before, that is significantly more robust, that will give us better predictability in terms of how much it costs to treat our patients. This chart gives you a little example of how different the two systems are. One of the basic differences between I-9 and I-10, of course, is the length of the code. And this requires a lot of retooling for our IT folks. 3 to 5 characters in length for ICD-9, excuse me, 3 to 7 characters in length for ICD-10. We had approximately 13,000 codes to work with in I-9, and by the time we're implementing it on October 1st, 2013, we'll have more than 155,000 codes. Now, that's not something to really panic about, because what you'll see as you look further, and we discuss this a bit more, is that the codes are not describing more diseases, but we have bundled codes with a greater degree of specificity that means we have more codes, not necessarily more diseases. On the I-10, the initial character is always alpha, and we have placeholders, but it's very, very flexible. We can use a number of codes and a number of characters to describe an assortment of degrees of pathologies or processes or sequela or underlying conditions that we were unable to use before. An example would be diabetes. I love using diabetes as an example because it's such a comprehensive disease that affects so many body systems. In I-9, we have diabetes with kidney manifestations. We have one code in diabetes that says diabetes with kidney manifestations. And in I-10, we have 3 that allows us to use for diabetic nephropathy, an unlisted, as well as end-stage renal disease or chronic kidney disease. So we have more granularity that's available. Some of the major differences that we have to learn, there's 4 major differences that our coders and our physicians and whoever else is driving the coding process will need to learn. First of all, that 7th character always has to be in the 7th place. So if your I-10 code is only 3 characters long and it requires a 7th character, we're going to need placeholders to maintain the integrity of that 7th character. So they use small x's, and they're simply there to hold the place so that when the claim is generated onto a computer system, that 7th character is always there. It's an extension, and it will give you additional information, generally about an episode of care. Another major difference is laterality. We now have right and left side of the body, and this is tremendous because very often patients are treated with an identical problem. A good example would be the wound clinic, where you have a right wound and you have a left wound. And we spend a lot of time identifying these codes and identifying with documentation to make sure that the carrier doesn't think that we're describing the same wound. They are different wounds on different sides of the body. And with I-10, we will have specific codes that will give us right side, left side, both sides. So there won't be any more mistaking what the intention was of the billing that went in. We have different excludes and include notes as well that will be required. But generally, we have the same types of rules and regulations. The sequencing rules are still the same. The rules about what a principal diagnosis is still the same. So we'll find that our coders and our providers, if they understand the rules and regulations for I-9, the main difference with I-10 is there's a lot more codes, and they look very, very different. Here's an example of granularity and organization of the new coding system. Now, I think this is a great example because it gives us an opportunity to look at a number of issues. First of all, you recall that I mentioned that we have some codes that are related to a problem and they're scattered throughout the book. Malunion, non-union, failure to mend, delayed healing is one of them. Notice that malunion of a fracture begins with a 733.81. It's in a totally different area than the original fracture, which is described with an 800 series code, 81418. It's an open fracture of the hamate. And what was described in the operative report is the open right wrist hook process of the hamate displaced. We have no way of describing that in the ICD-9. In ICD-10, we have S62.151B, which is exactly what that is, open right wrist hook fracture process of the hamate displaced. And the B means that it's an initial encounter for an open fracture. That's your 7th character. Now, when the patient comes back later with a problem with a delayed healing or a malunion or non-union of that same fracture, you notice the code is the same with the exception of the 7th character, S62.151P. And P means it's a malunion of that same fracture. So this will enable us to track better the types of pathologies because the code is the same. All that changes throughout that whole sequencing is the 7th character, which indicates to us the type of fracture, open or closed, the episode of care, and whether it's a malunion, non-union, or routine follow-up. So this is much more efficient code assignment. Once coders and physician providers get used to this type of assignment of coding, it becomes much faster. Now, once we learn the process, it'll be much, much faster for us to do. Another example, back to my favorite, of course, is diabetes. Notice that we have type 1 diabetic with severe non-proliferated retinopathy with macular edema. In order to communicate that effectively, completely, and precisely in I-9, I have to have a coder assign 3 separate ICD-9 codes. These can all be represented with one code in the I-10. So again, once we have the system down, it becomes much, much more efficient. Pressure ulcers of the right buttock, there's our laterality, stage 3, requires a minimum of 2 codes. It's one of the coding rules. When you have a pressure ulcer, you need a code that describes the stage. Here we have 1 code. So you can see how their codes are multiplied in the I-10 system, but they're not describing new diseases. We just have a specific code for every service or every pathology that at one time required a number of codes to describe them fully. We'll have fewer delayed claims, and this is one of the things that has been noticed in other countries that have been using I-10 for several years now, is because the codes are so precise, there is no need for carriers to be requesting additional documentation, for arguing about whether or not the service was appropriate or the diagnosis code was assigned properly. It's all in that 1 code. Coding is very, very descriptive. Now, the PCS portion, which is the portion that describes services provided to hospital inpatients, also has a number of objectives. Completeness, expandable, it's multi-axial. Now, PCS has not been updated since 1998. We do get annual updates as we do with other coding systems, but the PCS portion hasn't received a major update since 1998. The World Health Organization was not responsible for PCS, so it lagged behind and did not keep up with medical technology. So we find it's very, very frustrating for a coder to assign PCS codes to procedures done in the hospital because most of them really are grossly inadequate. They fail to represent the level of care that's been provided. It's infinitely expandable. It's a lot like SNOMED, which is a system used in pathology, or DSM-4, which is a multi-axial system. So each letter or number in PCS describes something individually. It's not like 250 means diabetes. The 2 would have a particular meaning, the 5 would have a particular meaning, as well as the O would have a particular meaning. That's what we mean by an axial system. Plus, it's classified by anatomy. Here's some of the differences. Currently, ICD-9 PCS has about 3,600 codes. 10 PCS has 194,000 plus. And there will probably be more by the time we implement on October 1st, 2013. It has 7 characters. Each one of the characters, of course, has its own meaning. And what's really exciting about PCS is it has very specific definitions. We have 31 root operations that have very specific definitions. And we have approaches that have very specific definitions. And then everything is run out by anatomical site. So the codes are very distinguishable. The data that will be available to us as a facility from the use of PCS will be tremendous. And of course, just like CM, ICD-10 PCS is infinitely flexible. And of course, coders can go directly to the tables should they choose. Anticipated benefits. Well, I can't tell you how exciting this is, because for a patient, they will have much better representation of what was done. They won't get a document from their insurance company with generalized codes on it or unspecified descriptions. From a financial standpoint, I anticipate that we will experience and appreciate improved billing, better collections, faster turnaround time, and much fewer opportunities for an insurance company to argue with us and decrease our reimbursement because the statements or the codes look ambiguous. And of course, the granularity, we'll be able to standardize our data with the data from the rest of the world, the rest of the country, and have much better clinical reporting and capabilities for our finance. Just to give you a little idea of how much PCS is going to save in terms of efficiency for coders, currently in the I-9 system, in order to communicate a percutaneous transluminal coronary angioplasty, a PTCA, with stent placement, 3 coronary arteries, 3 stents, a coder needs to look up 4 separate PCS codes. We need a code to say a PTCA was done. We need another one to say that a drug-eluting stent was placed. And then we need a code to say how many vessels were treated, and then another code to indicate how many stents were placed. And all of those have to be looked up and assigned carefully. In I-10, here's an example of what the tabular looks like. Those 4 codes that I just showed to you are represented by that one code at the top, 02725DZ. One code replaces 4 codes. And what it means is dilation 3 coronary arteries. Dilation is the root operation. Percutaneous intraluminal with intraluminal devices. And it's a table. And the first 3 characters come from the top. It's a medical surgical procedure on the heart and great vessels. And the root operation is dilation. So what used to require 4 separate codes now only requires 1. That's really great. It's not all the time that we have that type of transition where we go from a bunch of codes to 1 code, but there's enough of it there that I think that once coders recognize and appreciate and learn the system, that we will be able to see a much greater efficiency in the type of coding and the speed of coding that comes out of our coding department. So with all that in mind, what are we doing here at Washington Hospital to effect a good transition and to support our physicians? Because it's very important that we see to it that all the private practices for the physicians who serve at this hospital feel that they're getting the type of education and support that they need in order to effect this transition as well. Now, the cost of transition has been significantly inflated by a lot of governing bodies out there. There are a number of actuarial firms, the RAND Corporation, that have run numbers and said it's going to cost millions and millions of dollars and it's going to be extremely costly. And these figures, I want to caution you, are based on those facilities that have elected to outsource the entire transition. And there are many facilities like us that are selectively outsourcing only portions and working with our talent from within to create our own transition. This is the wisest approach because it's not only cost effective, but it means that you have individuals much more familiar with the way the hospital and the community operates, having the effect on the transition. It requires careful planning. It requires a timeline. And we have developed a timeline that we watch very carefully. And this particular timeline has identified tasks. It has responsible parties, milestone activities, and we watch it. We schedule them in a logical order. For example, with all of the education programs that are going on, we're doing very general educations right now. So we've addressed the board, we talked to the medical group, and these are all introductory seminars, and we'll gradually work our way down to a level of specificity until we're actually educating physician-level practices. Every good plan needs oversight to manage the project. And it's recommended that an I-10 implementation have a steering committee with a demographic that represents most of the stakeholders who will be involved. And that, of course, means just about everyone in the facility has some type of stake in a successful implementation of I-10. We identified that the RAC Oversight Committee was probably a very good committee since it had the type of demographics that would be appropriate also for the I-10 transition. And we have piggybacked on top of the RAC Oversight Committee and report in. The RAC Oversight Committee is responsible for making sure that we're on target. We can bring problems, updates, progress, and work with the individuals on that committee to see to it that we're on the right track. At some point, we'll also designate specific work groups as we get further along into this process. How are we preparing our physicians? This is really important to me. I've been working actually with professional fee providers longer than I have been working with hospital providers, so you will be very well taken care of. Out introducing bits and pieces of I-10 at various practice meetings. One initiated on April 19th for the critical care group. July 7th, we did a WITMIG presentation. August 10th, we're going to be initiating preparation for department level meetings. We're preparing for those now, doing a foundation presentation on the 18th, and then beginning on a medical staff presentation. Now, in addition to that, we're pulling the top 100 diagnosis codes used by each of the specialty areas, taking the first 25 and crosswalking them as best as we can to the I-10, and building a training session for that specialty on those 25 diagnosis codes. The remaining 75, I'll look over and see if there are any peculiar or unusual documentation requirements for those diagnosis codes. And we'll be developing some fun activities that we'll set up in the physician's lounge so that they could participate in these activities. We will also be earmarking or designating an individual in each practice, a staff member, who shows aptitude or interest who would like additional training in order to become the subject matter expert for that department or for that practice. So for the coders, and the coders here in the hospital, we're doing a daily ICD-10 trivia. We have a root operation of the month where we dig through that root operation and learn about different cases and how to code those cases based on each of those root operations. And some of them are very familiar, like resection. We all know what resection is. And then there are others called extirpation that are causing everyone a little bit of headache. So we have to work very carefully on some of those root operations. For physician practices, my first step is to find out how the coding is accomplished. Do they have coders? Does the physician pick out the codes, or do they use a superbill-driven process? Once we determine that, of course, then we'll again designate someone who's the subject matter expert and initiate some training in those practices, as well as provide some superbill assistance if necessary. Now, finance has challenges all around on this whole process, of course, and again, there are a lot of estimates out there. They're very large about the types of costs that may be associated with this transition. Probably the most reasonable method that I've seen of looking at the cost of transition is a percentage based on your gross annual revenue and the type of facility you are and the type of transition that you plan on having, whether you are going to be 100% vendor-driven or if you're going to have some of your internal talent manage part of the process as well. Based on those figures, it's estimated that we're probably in the $600,000 range, more or less, give or take a little bit, for this particular facility. We're hopeful that most of the carriers out there will transition over to I-10 very smoothly, but it's been suggested that those carriers who transition to I-10 may then turn around and take our claims and reconvert them back to I-9. Not because they can't do I-10, but because I-9 is a lot more general, and it will allow them a little bit more flexibility, shall we say, in how they reimburse. So part of finance's challenge will be to monitor the contracts to make sure they're performing appropriately, and that we don't have a conversion back to I-9 that will reduce our fair reimbursement. We'll have to watch out for early cutover dates. There'll be a period of time where physicians and hospitals will be dual coding. We'll be using coding for both I-9 and I-10. Patients who are discharged, regardless of their admission date after October 1st, will be on I-10, whereas some of the physician claims, part of them will be I-9 and part of them will be I-10. And of course, there are a couple of entities out there that are not required to transition to I-10. These are our non-HIPAA entities, such as workers' compensation, although California Workers' Comp has indicated they will transition, as well as some of the automobile associations. We have been worried, of course, about Medi-Cal and what Medi-Cal was going to do, because Medi-Cal occasionally will be delayed with some of their implementations of new coding systems, and the federal government has indicated that all state Medicaid societies will probably experience some difficulty, and they will be ready and able to assist and support those agencies in a successful implementation of I-10. The impact is going to be great. We're going to have a direct impact while we're learning how to use that coding scheme. Our productivity will drop. Coders will be moving a little bit more slowly. What we're thinking about doing in our particular area is using a software program called computer-assisted coding, which allows a coder to increase their productivity while they are learning the new system. And of course, our secondary impact is going to be just the whole management of the transition, monitoring activities. And of course, post-implementation, it isn't over when it's over. We're going to need to continue to monitor and make ourselves available to our physician practices as well as the facility, us in medical records, as a resource, as a valued resource that we can continue to answer questions and provide support. Already we're meeting regularly with different provider groups and giving them feedback both on their professional fee as well as their hospital documentation that's necessary, and I expect that some of these will increase. Like I said, this is a great opportunity for us. It's a huge opportunity for us to improve our clinical reporting, efficient billing, improved reimbursement, decreased delays and turnaround times. And once the system is learned, I think that all of us are going to appreciate the robust quality of the data that we get for learning how to use this system. It's a great door, it's a challenge, it's a great opportunity, and I'm ready, and I know everyone else is ready as well. Does anyone have any questions for me?
Wanda, that was probably one of the best presentations that I have heard in a long time.
Thank you very much.
And
That's-
I've been very concerned about the transition because we're both speaking the same language, but I
we
feel...
do have a private language, yes, no?
Yes, we do, don't we? I feel much more comfortable now, and I would just tweak your presentation one little itty bit. I have had no success in over 2 years in describing the change based on the numbers of the codes in the current system versus ICD-10. So I switched. My book weighs 5 pounds. I put it on the scale. That and showing it to them had an impact. So sometimes visual has more of an impact than just telling them what it is. But I feel very comfortable, and I know that we're going to have a lot of challenges. I also feel very happy that you're going to be working with the physicians because it's going to be very difficult, I think, for them, very challenging, to transition from 9 to 10 because it's going to just happen from one day to the next.
Yes, you're
So
absolutely right.
I feel very comfortable with the plan, very comfortable.
Thank you.
Thank you.
It is going to be very challenging for our physicians. Just looking at a super bill alone, if we consider the real estate on a paper super bill, and you were going to put all the codes possible on there that you might be willing to use, it would have to expand 7 times. And there's also been a lot of talk about the GEMS, the general equivalence mappings, that these are going to be the answer to our prayers. We can just plug everything in and it'll convert. But not everything converts as a one-on-one basis.
No, it doesn't.
So it's really going to require a lot of retooling, and we're prepared to support our physicians.
Well, I'm retooling my brain now. So, we'll keep going.
Other questions, please?
Bill, do you have any questions? Okay.
I'm still a
He's-
little shell-shocked.
He's stunned.
He's stunned.
So
I
maybe...
guess my only question is, what role do you see that physicians will be taking on ensuring the accuracy of the coding on a patient-by-patient basis? Because the patients, I mean, the physicians understand exactly what's going on with their patients, at least we hope we do. And the remarkable thing about this system of coding is its level of specificity, that granularity that you were talking about. And so what I'm struggling with in my own mind is how physicians, what role will physicians have in determining that level of coding? Is that something that they're going to do on a visit-by-visit basis where they know or will have some quick computer solutions to get down to that seven character code promptly?
Well, I'm going to answer it in different parts here. First of all, my experience of looking at physicians' documentation is that for the most part, the level of granularity that I need to code it in I-10 is already there. And it's really fairly simple. It's a left side, it's a right side. It's already there, and our frustration has been we don't have a code to identify what it is that you've put in the medical record. So this is the granularity that you need to document, for the most part, is already there. And in a number of presentations I did, I took one note and then added to it what was necessary in order for me to be able to effectively use I-10. And in the entire history and physical, it was a matter of 3 words. So we're really not looking at a huge amount of effort now from our providers to increase. In terms of whether or not the codes that we assign are correct, I expect that during the initial monitoring activity, that there'll be a fair amount of interaction between coders and physicians, not like the queries that we write asking questions about, would you clarify this, would you clarify that? But there'll be more interactions where we sit down and work and talk about the documentation, what the codes were that were generated as a team. And I do some of that right now with the wound clinic, where we get down and we look at some of the codes, some of the documents that I've reviewed, and what should be added, what isn't added, what types of codes are resulting from the documentation that's presented. So I see that your role will be just initially to participate more with us in whatever way works with your schedule, as we all get used to this. Was that answer your question, sir?
It's helpful, thank you.
Thank you. Other questions, please?
Bernie, just a question. Dr. Stewart is a dentist. Is ICD-10 going to affect him?
For diagnosis codes, yes, but for dental work, I believe you use the D category for the Hicks-Picks book. And so those codes will not be changing.
Great relief to me.
Pardon me?
You got lucky.
That's a great relief to me.
That's a great relief, right? The CDT, right, the current dental terminology, which is the D portion of the Hicks-Picks book.
Yes,
That will
he's-
remain unchanged. But for your diagnoses, and I would imagine that the diagnosis codes that you use will be in a very circumscribed area. They're not going to be as extensive as if you were a general practitioner or a surgeon. They're going to be fairly specific. It should be relatively easy to retool whatever document or system that you use to communicate the reasons why the patient's seeking dental care.
I have to add one more comment. As a student many years ago, I was given the opportunity to learn Snowdo, which gave me Excedrin headache number 1 through 1,000. And I couldn't find any real use for it, except now I can, because it gave me a good introduction of changing the way that I think about coding to what is going to happen with 10.
Yes.
So, but I've never, this is the first time I've heard Snowdo mentioned in the public, ever.
Snowdo and SNOMED, for those of you who don't know what it is, those are coding systems that were used by pathology, and they're a multi-axial system, very much like PCS. And they're still used. Well,
is?
in many cases, yeah. I know UCSF still used SNOMED.
Thank you.
Anything else? I'm sure that there'll be questions. Here is my contact information. Please feel free to contact me with any questions. And again, thank you very much for the opportunity to address the board tonight.
That was the less painful part. That made sense to you?
I've had opportunity to work with Wanda, and she's made it very clear, even to
Good.
me. So
Good.
that's a great
No,
sign.
it was very clear. Today I signed up for another class. So, and I'm just hoping that the instructors are half as clear as she is, but it was very, very well done.
I think we're very lucky to have Wanda here.
Oh, yes.
To help us through this, because for a lot of institutions, it could be mission critical if it's not done properly, and I have confidence that she'll lead us through this.
Yeah, I'm afraid that a lot of institutions and hospitals are going to wait until maybe February or March of 2013. And by that time, it's going to be havoc.
Too late.
Too late. Yeah, they're really going to have a problem. Okay, on with our agenda. Our next item is consideration of the minutes of July 13th, 18th, 25th, 27th, and August 1st. We need a motion?
So moved?
Second?
Second.
Moved and second. All in favor?
Aye.
Motion passes. Thank you. Catherine, do we have any oral communications? I don't see anyone. Okay. Thank you. No oral communications. Written communications. Dr. Romano.
Thank you, Madam Chair, members of the board. It's my pleasure to present the credentialing action items for your consideration. First will be the appointments. We have 7 new appointments to recommend. Dr. Samira Aliabadi is joining the ambulatory staff status as a provisional member. Dr. Cyrus Shariat is joining the intensivist group on the active staff. Elizabeth Torek is a physician's assistant who will be joining Dr. Jeffrey Carlson and will be a member of the provisional allied health section. Dr. Anjali Kandapal is joining the provisional active section of family practice. Javon Tang, infectious disease, is joining the Washington Township Medical Group. will be provisional active. Excuse me. Dr. Barum Varjavan is a neurointerventional radiologist who will be joining the courtesy staff. And finally, Kate Wong is a physician's assistant being supervised by Dr. J.C. Walks. For reappointments, we have Krista Amendola, Anita Bandia, William Brown, Jing Dai, Neil Dickler, Desmond Erasmus, Kareem Hussein, Alita Jacobs, Nirmala Kanan, Elizabeth Kirkjian, Stacy McDonald, Dimple Marwaha, Russell Nord, Donald Pang, Kavira Patel, Tirupathy Reddy, Catherine Saxton, Millie Shah, James Tagle, Hete Win, Ming Wu, and Lanshin Yang, all being reappointed to the active staff, except for Dr. James Tagle from teleradiology, who will be continuing in the courtesy staff. There are several others who we will note later will be transferring their status. Dr. Engers will continue in his conditional reappointment while he is on probation with the Medical Board of California. Transfers in staff status, Dr. Sarkis Benapalsan, active to ambulatory. Arun Srivatsa is going provisional to active. Kaviri Patel, active to ambulatory. Ming Mu, active to ambulatory. Nirmala Kanan, active to courtesy. Lenny Martinez, moving to the retired staff. And Carrie Robertson, a physician assistant, moving from provisional to the allied health professional section of our medical staff. We're requesting discontinuation of proctorship and staff status advancement for the following members. Ki Chi, the initial core and for plasmapheresis, proctorship has been completed and moving from provisional to active. Dr. Campella, initial core proctorship completed, moving provisional to active. Dr. Kavitha Raj, initial core proctorship, moving provisional to active. Dr. Shalini Sundar, initial core and plasmapheresis proctorship completed. And Dr. Daniel Sweeney, initial core proctorship completed, moving provisional to active. Discontinuing proctorship will be Drs. Benjamin Bach, Brian Burgoyne, and Kathy Keller, all for their initial core. They are all members of provisional courtesy staff. We would like to extend the proctorship and staff status advancement for an additional 6 months through February of 2012 for Drs. Lisa Buhar and Koinis Enix until their proctorship is completed. Dr. Jacobs was previously on provisional active, has completed her proctorship, and now we would like to discontinue that proctorship and move her from provisional active to active. Dr. Ki Chi is withdrawing the special privilege of moderate sedation. And finally, Dr. Heather Harris is resigning from the medical staff due to a change of employment. Are there any questions? Thank you.
No. We need a motion to approve.
So moved.
Second.
It's been moved and seconded. All in favor?
Aye.
Motion passes. Thank you. Nancy, I believe you're going to fill in for Andy, who's not able to be here
Not
tonight.
able to be here
for the
this
Service League.
evening.
Thank you.
The report I have from the Service League is all is well in the Service League. Their league volunteers have been busy this summer. Because it is summer, they have a lot of student volunteers who are available during the day shift, and this creates the opportunity for the students and the staff, along with the adults, to work side by side. Both adults and student volunteers signed up to help at the concerts in the park with the hospital's booth and the neuroscience symposium, and to help WHEA at the Festival of the Arts. The gift shop committee has been to 2 gift shows, one in Atlanta and one in San Francisco this summer. They are preparing for a holiday gift show to be held in the gift shop on November 10th and 11th. The committee not only shops for the items, they place the orders, receive the items, open and unpack all the boxes, place tags on each item, enter the information into their computer, and then take the items to storage for the gift show. They put a lot of work and energy into not only the day-to-day upkeep and managing of the gift shop, but they also turn the gift shop into a wonderful holiday gift show in November. So I want the board members to mark their calendars. Each year, all of our volunteers need to complete mandatory safety training. This training was done on August 1st in a carnival theme here in the auditoriums. High school, college, and adult volunteers staffed booths and carnival games. The volunteers trained 204 fellow volunteers on how to operate a fire extinguisher, wheelchair safety, quizzed each other on the emergency codes, fire drills, patient safety, security, and hand hygiene. The quilting committee is finishing up their quilt called Happy Scraps. The quilters hope to have the quilt ready to start selling tickets soon and have the drawing at their annual meeting in February. Quilters are also creating a beautiful lap quilt in pink patterns to use as a drawing prize at the Think Pink Breast Health Awareness event to be held in October. So if you want to take a look at the quilts and get an advanced peek at how they look, you're certainly welcome to come by the volunteer office upstairs here in Washington West.
Thank you.
That's the report.
I hope Andy feels better soon. Miss him. Now, Dr. Romano, we're back to you with medical staff report.
Well, thank you. Well, my medical staff report is the following. We now have 522 members of the medical staff, and even 400 of them are active and provisional active members. We have 21 total pre-applications in process. We have 24 applications in process. And we have 7 applications presented today and another 5 anticipated for next month. And there are 3 temporary privileges having been processed. Thank you, that's all.
Thank you. Thank you. Nancy, we're now ready for the hospital calendar.
Reports. Before I wade into the calendar, I'm going to start by asking Kent Jornstad to come to the podium and talk about the 4-H livestock auction.
Look at them spurs.
Oh gosh, he's got spurs on, you're right.
And he's even clinking.
All right, I am Ken Jernsted, but I also have other qualifications. I've been farmer, hayed, put up, I have a ranch, and I've also had horses. But anyhow, I'm just trying to get my credentials right. So anyhow, the Alameda County Fair Junior Livestock Auction was held on July 10th. I accompanied our CEO, Nancy Farber, on this excursion. Our mission, to purchase quality livestock for members of our area 4-H and FAA clubs, the Future Farmers of America. Weeks before the auction, we began to receive wonderful letters from the students describing their animals and all the hard work involved in preparing them for auction. Their efforts were apparent by the show of many quality animals. We enjoyed a fun-filled day, including a barbecue, and you guessed it, it was ribeye steaks, perfectly barbecued with all the fixins. And in addition, Nancy and I were presented with some very thoughtful thank you gifts, which we have donated to WIA, which is our Hospital Employee Association, and we used some of them during our Magnet Blitz in preparation for our visit last month. It was an exciting auction, and Washington Hospital ultimately purchased 14 hogs, and 1 was awarded Supreme Champion, 4 lambs, and 3 steer this year. Of course, the number one question that I always get is, now what do you do with these livestock? And the answer is, we process the livestock and serve them to our staff and patients. This day was a rewarding one for me, as it was for the auction participants. As always, it was a pleasure and a privilege to be part of an institution that supports community through action. I'm already looking forward to next year. Thank you.
Hey, you can't. At least with my livestock, I don't need to wear spurs. With my livestock, I don't need to wear spurs.
You don't wrangle turtles. Or birds.
Or birds.
The next report we're going to have as part of the calendar will be the construction update from Ed Fan.
Okay, so we'll start with a brief discussion of the central utility plant. Well, not a lot of new things to see here, in that we're into the commissioning phase, and a lot of work is now being done, bringing things online. So here you can see that the brickwork is continuing into one of the roads into the one of the yards that will be a support yard for the plant. And then you can see that the foliage, trees, shrubs, things like that are being brought in and are starting to be planted around the perimeter of the central plant. Going to the CJR, we have more work going on outside. So this is a retaining wall that's going on up on the south side of the CJR, and this is work that's beginning to take place on the garden that's going to be the exercise garden. So this is actually a step down into the garden area that they're beginning to put the rebar down, and then we'll be pouring concrete. And then the walkways and garden, the exercise garden, will go down around the east side of the building. This is just more asphalt being taken out of the area that will become the exercise garden. This is the second floor of the CJR, and this is a hallway that goes in front of the window wall and is connecting the inpatient unit to the physician office space that's in the north side of this building. And windows are beginning to go down into the first floor or the basement area of the CJR, and that's being placed. So we're still making good progress here. We did run into this month. We had some delays in the CJR, specifically for we were stopped for a period of time by OSHPD because we didn't have final approvals on everything on the second floor, so that caused a delay of between 10 days and 2 weeks. And but outside of that, the central plant is still going on time and on schedule and within budget. CJR, will put us back a little bit, but I think it's something that we can still catch up and still look at the April timeframe for completion.
Very good. Thank you.
Thank you.
Questions, gentlemen?
No, great work.
Looks good. Thank you.
Okay, we'll start with the rest of the calendar on July 13th. We had a program at the Washington Women's Center. The program was about menopause and weight gain. We had 26 people attend. Macaria Meyer, registered dietitian, presented on menopause and weight gain and how to maintain weight or lose the extra pounds. On July 19th, we had a program on cataracts and diabetic eye conditions. We had 33 people in attendance. Dr. Sarb Handal, ophthalmologist, presented this seminar. On July 20th, we had another program at the Washington Women's Center, and the subject was food and mood. What's food got to do with it? And Achal Bengal, registered dietitian, presented this seminar. We had 20 people in attendance. On July 21st, 28th, and August 4th, we did community outreach at the Central Park Summer Concert Series here in Fremont at Central Park. We were the presenting sponsor. Over 750 people visited our Washington Hospital booth. On July 26th through the 28th, we had our magnet survey of the nursing program in the hospital. And while, like most surveyors, they don't tell you at the time of survey what the outcome of the survey is, they were very encouraging to the hourly employees who they met with and did tell them that we should have applied for magnet a long time ago and that we were exemplary in most categories, and have suggested that in areas where we excel that we should be publishing. What happens after the survey's conclusion is that they go back and write an extensive written report. And sometime in October to December, we'll get a telephone call, and they will tell us whether or not we've achieved magnet designation. I think the nursing division and the rest of the hospital acquitted themselves very well during the course of the survey. And there was nothing other than pride and enthusiasm, and I think the board should be quite pleased. I have every expectation that we'll be successful in our bid to be designated as a magnet hospital. On July 29th, we had a program on health insurance options. ProNet is an information service for people looking for jobs, and they also want to make the connection on how to go about finding health insurance when you're uninsured. And so our health insurance information service, Linda DeWall, the coordinator, was there at the Fremont Family Resource Center, and there were 50 people there. On July 29th, we had a community event, one that I have to say I didn't look forward to, and that was saying goodbye to Father Jeff. We had over 200 people come, and we hosted a farewell celebration to honor Father Jeff Finley as he continues on to his next assignment as the provincial director of the Atlantic Province with the Missionaries of the Precious Blood in Toronto, Canada. Father Jeff has served as a volunteer chaplain, a spiritual care and palliative care coordinator at our hospital, and he also was pastor to the Dominican Sisters here in Fremont. To say he would be missed is an understatement. On July 30th, we did our tattoo removal project at Washington Urgent Care Center, and again, Dr. Barbara Kostick volunteered her time and provided this service. We had 23 people have tattoos removed. On July 31st, we had a community event, the Little League Day at the A's, which the hospital sponsored at the Oakland Coliseum. And Little League players from Washington Township District participated in a coaches clinic where the Oakland A's coaches worked with Little League players on essential baseball skills. The coaches clinic was followed by a presentation by Dr. Jacqueline Labad, family practice medicine physician from Washington Township Medical Foundation, and Mike Rogers, who's manager here at the hospital, on the importance of maintaining your health through exercise. Players were able to march onto the field with the players for the national anthem before the start of the game. We had 80 Little League players participate, and I think some of you know Tina Nunez. Her young son participated in this, and on the way home he told his mother it was the best day of his life. So I think it was a pretty special day for some Little League baseball players. On August 2nd, we had our stroke program present acute management of stroke and chronic care and stroke management. As always, Dr. Ash Jane and Doug Van Houten, RN, presented this program and did a wonderful job. We had 13 people in attendance. On August 6th and 7th, we were at the Fremont Festival of the Arts here in Central Fremont. We hosted an information booth in the business alley. We had staff from various departments providing information on Washington's programs and services, as well as the volunteers helping us. Over 40,000 people attended, and several thousand visited the Washington Hospital booth. In terms of upcoming programs, we're going to be doing a program on August 16th on diabetes, diabetes and lifestyle choices from 11 until 12 noon at the Nakamura Conference Center, which is in Union City. On August 23rd, we'll be doing community education on the prevention of heart disease and healthy diet for your heart from 1 until 3 p.m. here in Anderson Auditorium. And Dr. John Cecil Walks, our cardiothoracic surgeon, is going to be presenting this program. On August 24th and 25th, we'll be doing community outreach at the ISE Labs Open Enrollment Fair from 4 until 7 p.m. And Vida Reed, RN, who's a certified diabetes educator, and laboratory staff Matt Ybarra, a respiratory therapist, will be providing glucose and cholesterol screenings and lung capacity screenings for the employees of the lab. They manufacture semiconductors. August 30th, we'll be doing community education on the subject of treating infections in the body and learning about sepsis. It will be held from 1 until 3 p.m. And Dr. Carmen Aghuili, our critical care intensivist and medical director of the intensivist hospitalist program, along with Dr. Naveen Bhatti, emergency medicine physician, and Katie Choi, RN, will be the faculty. On September 6th, we'll have another program on stroke. The subject is healthy lifestyle, be smart to avoid stroke, and it will be held from 7 until 8 in the evening here in Anderson Auditorium. Dr. Ash Jain and Doug Van Houten, RN, will be faculty. On September 10th, we will have our 4th annual Men's Health Fair from 9 in the morning until 12:30 p.m. Doctors Mark Saleh, who's a urologist, Stephen Curran is a family practitioner, and Macaria Meyer, among others, will be presenting. Dr. Albert Brooks, Chief of Medical Services, will moderate the program. And the Men's Health Fair will cover topics related to prostate health, kidney stones, nutrition to promote overall health. The lectures will be followed by a health fair, which will include various screenings. On September 12th, we'll be having the Women's Center present another program, and this subject is sleep and menopause. And Dr. Nitin Verma, our sleep disorders physician, will be the faculty. On the 13th of September, we'll have a program on how to maintain a healthy weight, and good nutrition is the key, and it will be held from 1 until 3 in the afternoon. Dr. Prasad, OBGYN, and member of the Washington Township Medical Foundation, and Kimberly Alvari, registered dietitian, are the faculty. And the foundation will be celebrating the 25th anniversary of Top Hat in October. This is their annual dinner dance, and it will take place on Saturday, October 8th, in the tent at Washington West. This year, proceeds from the gala will support the construction of an outpatient infusion center where cancer patients will receive chemotherapy treatments in a comfortable spa-like setting. The entertainment this year will be provided by the Joe Chirino Band, which has a large local following in the district. Tickets and sponsorships are available now. Washington on Wheels in July continue to serve the community in all the usual places: the Fremont Senior Center, the Fremont Family Resource Center, the Silliman Activity Center in Newark, the Ruggieri Senior Center in Union City, and the NUMMI Reemployment Center. WOW also provided services at Central Park Summer Concert Series, and they continue to provide the whooping cough vaccinations in order to assist students in meeting the new California state requirements for that vaccination for all children entering the 7th through the 12th grades this fall. They continue to do the free summer glucose screening services. They've provided free glucose screenings for 74 individuals, with 4 founding to be at high risk. Currently, 2 of the 4 found to be at high risk for diabetes are being followed by their personal health care providers, and 2 are being followed by the WOW Clinic. In terms of internet marketing, our website had 35,022 visits, 22,823 unique visitors, which resulted in 110,288 page views. The most visited links included the employment section with 24,172 page views, the physician finder section at 16,374 page views, the volunteers page with 8,908 page views. The section on About Washington Hospital Healthcare System had 9,396 page views, and the Women's Health and Pregnancy section had 3,217 page views. InHealth, Channel 78, during the month of July, completed several new productions, including capturing the 5th Annual Neuroscience Symposium and health and wellness classes about cataracts and diabetic eye conditions, as well as benign tumors and how they're treated. Staff also captured the Citizen Bond Oversight Committee meeting, as well as new surgical procedure performed by Dr. Jan Hansdorf. Finally, the staff completed production of a music video related to the Magnet Journey. WHEA also participated in the Fremont Festival of the Arts this year. It is their largest fundraiser. They turn our parking lot into a pay-for parking lot on Saturday and Sunday during the festival. They had over 42 volunteers, including volunteers from the Service League to collect parking fees, direct traffic, distribute handouts, sell water, and provide relief breaks. They raised $8,217.81. The WHEA sponsored a wine tasting bus trip event, and this is going to take place on Saturday, August 13th, and they will be visiting wineries in the Livermore Valley. The back-to-school supplies drive began on July 25th and will run through August 19th. Items received will be donated to the Save shelter, and they're collecting backpacks and school supplies. Now, the Employee of the Month for August, Megan Tehran. She is a clinical pharmacist who started at our hospital in October of 2007. She graduated from the University of Pacific Pharmacy School, excuse me, with her doctorate in pharmacy the summer of 2005. She continued on and obtained an additional year of training as a pharmacy practice resident at the VA Loma Linda Healthcare System. After her residency year, she started her career as a hospital-based specialist clinical pharmacist with Kaiser Santa Clara for 1 year. She then decided to join Washington Hospital on October 22, 2007 as the critical care pharmacist. She is a well-rounded clinical pharmacist, and comments from her staff include enthusiastic, friendly, detail-oriented, conscientious, and always helpful. That's exactly what you want to hear about a pharmacist. She always comes to work with a smile on her face. She's a true delight. And she is recognized by her peers and other members outside the pharmacy department for her patient-focused care. So we want to congratulate Megan.
Now we're ready for Stephanie and our quality report.
The quality focus tonight is going to be on our Joint Replacement Center. And as you're aware, it's an award-winning, national recognized program. So you will hear a little bit about it tonight in terms of some of their quality outcomes. The Joint Replacement Program started back in 2000, and it has grown tremendously. As of 2011, we have done, for this year only, we have done 1,277 joint replacement. We have put in 843 knees in a total of 694 patients, and we had done 434 total hip arthroplasty. Let's look at some of these outcomes. This is talking about flexion, and the knee flexion is measured by the physical therapist prior to discharge. Why is this important? Because early range of motion predicts better outcome. It prevents scar formation, which impedes the range of motion. So you want to have that ability to be able to move your knee fluidly. And as you see, the goal is to achieve it 90 degrees of flexion 80% of the time, and we have continued to exceed. Looking at the extension. This is important because prior to surgery, most patients come in limping. Once they leave, they walk straight. The knee is able to be straight. So it's really important, and this is also measured at the time of discharge. The goal is that a patient will achieve less than 5 degrees of extension 90% of the time, and we have continued to exceed in that as well. Let's talk a little bit about the length of stay for the total knee arthroplasty patients. Our overall length of stay is 2.7 days. For bilateral, which means both knees are done, is 3.2 days. And the single is 2.5 days. And if you have a partial, it's 1.4 days. And you may ask yourself, why is the length of stay so short? Well, it's because it's a program. And the emphasis on the program is on education, is on pain control, and is on patient as part of the process. From the time the patient sees the physician for the first visit, through the pre-op, through the discharge process, the expectations are set. So the patients know exactly what's going to happen to them, when it's going to happen to them, and what the outcome should be. So with that in mind, they go home, and they go home in a lot sooner than expected. Our length of stay is a lot shorter than most of the hospitals on a national basis. Looking at the destination in terms of where do these patients go, 92.4% of our patients go home. We want them to go home. In many other programs, these patients end up going to a nursing home and then to home. For the bilateral knees, and it's a very complex surgery, you have both knees done at the same time, we are still able to discharge 92.6% of the patients home. How do we measure success in terms of knowing that we have done what we are supposed to or claim that we have done? The Knee Society score is an evidence-based tool that is used by the surgeons to rate the pain and function of total knee replacement patients over time. The current tracking compares the pre-op scores to the post-op scores at 3 months. So the average pre-op score is 58.7 on admission. The range is between 16 and 90. At 3 months, the range is between 77 and 100%, but our patient achieved a score of 97%, and that is exceedingly well. Let's talk a little bit about the hips, the hip replacement. Again, one of the reasons why we do so well in this is that they go home in less than 1.6 days. 93% of the patients go home. One of the things that's emphasized on discharge is the complication of the hip happens within 6 weeks. So we make sure that they are well educated so that they be able to demonstrate flexion before they go home. Again, looking at the tool that we use, and these are national recognized tools, they're evidence-based tool, and it gives you a good comparison in terms of how you can compare and how you can benchmark against the best programs out there. The pre-op scores for our patients is 70.1. The range is from 0 to 100. But 3 months post-op, our scores are ranging 94.5, and the average range is 63 to 100%. Talking about VTE prophylaxis, and that's a clot in the vein, and that's a post-op complication that usually happens after surgery. We have a very aggressive VTE program that's usually involved all the surgeries. We have reported that data with a skip. So there is a protocol that we follow on all patients. And you have seen that over time, look at our results in terms of the patients that go home without any deep vein thrombosis. 70% of our patients are screened between 3 days and 1 week after surgery. And we have seen a significant drop in VTE from previous years. And that's because we do have a protocol in place that's applicable to all surgical patients. talking about pain management and customer satisfaction. This is the patient perception of pain, and as you know, we receive a health grade award as it relates to pain management. And this is part of the program. This is built into the program. This is one of the things that's emphasized during the program in terms of the pain control. We get them up early, we get them moving, we get the pain control, we get them educated, and then we get them involved in their care. And overall, that's a recipe for success. And we have continued to range, and this is a percent excellent. This is not the mean, this is not the average. We continue to show, based on the PRC data, that we rank in the 92 to 96% excellent percentile in terms of pain control. And that's just a brief overview of some of the quality indicators for our joint replacement program. Questions?
I'm still amazed that you can go in and get a hip replaced or your knee replaced and you're back home in a couple of days. It's fantastic.
It's awesome.
Yeah.
And it's worth reminding everybody it was ranked as the #1 orthopedic program in the state of California, ahead of all of the universities and other centers of excellence.
I think the key is the education part of it, before, during, and after.
That's an important part in making the patient a partner in care. But I think also you have to recognize the considerable surgical skills of John Dearborn and Alexander Saw, as well as the excellence of the staff on the unit in terms of physical therapy and occupational therapy, the nursing. I mean, everybody functions as a team,
It is a team.
and it shows.
Yeah, it does. Those are good numbers. Comments?
No, I think the operative word here is teamwork. And they've been able to develop the right protocols and procedures to make sure the patients have outstanding results. It's quite easy to see why this is the #1 ranked program when we look at the quality data. And the good thing that they're doing is that they are looking at the quality data. I would challenge other institutions to do the same.
Thank you, thank you. That brings us up to Chris Henry and our finance reports.
Okay, tonight we will be looking at the results of operations and finance for June 2011 for Washington Hospital. And as always, we'll start with our operating indicators. Average daily census for June came in 6.7 above the budget at 177.5. We had 1,089 admissions, that's 34 above the budget of 1,055. And our patient days were 199 above the budget at 5,324. Our average length of stay for the month came in at 5.11. We'd expected 4.86 in the budget. Moving into utilization, our case mix index for June came in pretty darn close to budget at 1.365. Our deliveries for the month came in 7 above the budget at 185. I think that's the largest number of deliveries we've had in a number of months. Surgical cases for the month came in 8 below budget at 352. That included joint replacement cases that were 6 above the budget at 100 even, neurosurgical cases that were 7 below the budget at 12, and cardiac surgical cases that were 5 below budget at 10. PTCA's procedures for the month came in 17 below budget at 55. However, outpatient visits for the month were 182 above the budget at 9,194. We had 4,118 emergency room visits in June. We had expected 4,187, so pretty close to budget there, and still a very high level of activity. Looking at productivity, our productive full-time equivalents for the month came in at 1,392.2. We had 208 non-productive FTEs for the month, giving us total FTEs 161.1 above the budget at 1,600.2. Our FTEs per adjusted occupied bed, which is our productivity measure, came in a little bit above budget at 6.85. We'd expected 6.5, But with all the activity around magnet surveys, and we're expecting Joint Commission any day, it's driven a lot of activity over the last couple of months, so it's driven that number up. Year to date, however, you'll note that we're darn near right on budget with our productivity, so it's good performance this year. Moving into the financials, as always, we'll go through our Government Accounting Standards Board presentation. I always like to remind folks, for those who aren't familiar with this, this is the presentation that we use for our audited financial statements. Total patient revenue for the month came in a little over $5 million above budget at $153,913,000. Our contractual write-offs for the month came in a little bit above the budget at 73.96%. We did have a higher level of government-sponsored patients during the month, and that tends to drive higher write-offs. So we end the month with net operating revenue a little bit over $1 million above budget at $40,454,000. Operating expenses for the month came in a little bit over $1.1 million above the budget at $38,168,000. That variance largely being driven by our salaries and wages with our higher level of FTEs and the higher, resulting from the higher level of productivity in the house. We also had variances in bad debt that was above budget. That's driven largely by our higher revenue. It's directly related. Those were offset by benefits that were below budget during the month. We saw that largely in health and welfare costs. Supplies were below budget, and also pro fees. So we end the month with an operating bottom line pretty darn close to budget at $2,286,000. Non-operating income for the month actually about $801,000 below budget at $538,000. That driven again by the volatility in the financial markets. Had an unrealized loss in our investments, almost $1.2 million. So we end June with a total bottom line from a GASB perspective about $890,000 below the budget at $2,824,000. But June being the last month in the fiscal year, we had a very strong financial performance again in 2011. So congratulations to everybody. Again, we'll move into our Financial Accounting Standards Board, and this is the way that the financial markets tend to look at us. Operating margin and operating bottom line stays the same at $2.286 million. We remove our property tax revenue, which services our general obligation bonds, and the unrealized loss on our investments to come up to non-operating income $340,000 above budget at $999,000, and a total bottom line for June $251,000 above the budget from a FASB perspective at almost $3.3 million. So are there any questions on June results?
I don't have a question on June results. I have a question on events in August.
We're talking about the stock market.
Can you say how the short-term fluctuations in the market might affect us financially? Do we have any?
Insofar as our investment portfolio goes, short-term uncertainty in the markets tend to drive a flight to fixed income securities, and we typically see an unrealized gain in our investments, and I expect to see that in July and August. I haven't seen the final numbers on that yet, but that's typically what would happen. So because we're conservatively invested, we don't hold any equities, that does not impact us. So fluctuations in the equity markets don't directly impact us. They indirectly impact us in the flight to what's on the financial markets call a flight to quality, which tends to be high quality fixed income securities, which is what we hold. Mm-hmm. So we typically benefit from a down equity market as we're seeing right now. Mm-hmm. And also uncertainty. The market hates uncertainty.
Yes, it does. Thank you very much, Chris.
Sure.
Thank you. Nancy, you ready for hospital operations?
Yes. So I head into the description of the preliminary results in July. I want to make a point of letting the board know that 2 of our biggest emitters in the cath lab were gone for extended periods of time during this month. July saw the admission of 1,057 patients that resulted in 5,628 days of care. The average daily census for July was 182, and this was higher than June's, which came in at about 177. The high and low census ranged from 207 down to 138. The budget for July anticipated 1,011 admissions and 5,417 days of care, and an average daily census of 175. So we're going to be about 211 patient days of care above the budget for the month. The average length of stay for adults and children in July was lower than budgeted. It came in at 5.17, and we had budgeted 5.36. In terms of revenue for the month of July, it is approximately $124,209,000 compared to a budget estimate of $121,289,000. Of this amount, 46.7% was Medicare and 12% was Medi-Cal, for a total of 58.7% in program revenue. The birthing center saw 168 deliveries in July compared to a budget of 184. Our newborns totaled 169. In surgery, we had 335 surgical cases at the hospital versus a budget of 392. We also had a number of surgeons absent during this month. This includes cardiac surgical cases that came in 13 below the budget at just 6. The inpatient surgical activity was below budget by 29 cases. Outpatient surgeries were below budget by 28. 531 cases were seen at the outpatient surgery center versus a budget of 542. For the month of July, we had 313 cases seen in the cath lab, including 31 PTCAs. Total cath lab cases were lower than budget by 113. And PTCAs were lower than budget by 34. We had 39 fewer inpatient cath lab procedures than we had planned, and outpatient procedures were 74 lower than expected. Non-emergency outpatient visits for the month of July amounted to 8,642, and that was below the budget of 9,074. Emergency room recorded a total of 4,252 patients with a daily average of 137. They came in 6 above budget. Washington, Warm Springs, Newark, Nakamura, Walmart, and Ohlone clinics saw approximately 3,852 patients during July. The total system emergency room and clinic visits for July are 8,104 compared to a budget of 8,590 visits. Full-time equivalents for the month of July totaled 1,630.9, and they're coming in very high. This is a 3-survey summer. We've been through Magnet. We have Joint Commission ahead of us. They'll be here either next week or the week after. And we also have a stroke program survey with the Joint Commission that could happen at the same time, but might not. So we have extra staff on board as we are in a holding pattern for these surveys. The budget had called for 1,526.2. Our adjusted FTEs per adjusted occupied bed for the month are at 7.02. The budget was 6.74. In summary, we had 46 more admissions and 211 more patient days than anticipated in the budget. The surgical cases were below budget by 14.5%. Cath lab procedures were below budget by 26.5%. Outpatient visits are 4.8% below budget, while the ER visits were higher than anticipated. Total paid FTEs are above budget by 104.7 for the month and above the last 12 months average. FTEs per AOB are above budget. Inpatient charges for the month are higher than budget by approximately $2,920,000, or 2.4%. Outpatient charges are below budget by approximately 2.9%, or $1,021,000. So our total hospital charges for July are going to come in above budget by approximately $1.8 million, or 1.2%. On July 31st, there were 166 days cash on hand. The total days revenue and accounts receivable at July 31st was 65.25. The days revenue and accounts receivable excluding Medi-Cal is at 60.21. During the month of July, $3,051,463 of charges were approved or are pending for charity assistance. I can tell you by reviewing each of those accounts with Chris Henry and Stephanie Williams, these are truly people who cannot be expected to pay their bills. They don't have the income requisite and they're not insured. And there are people who are working sometimes multiple jobs without benefits, trying to keep their families' hearth and home together. And this is a difficult time for a lot of people.
I'm thankful that we're able to help them.
I'm thankful that we can help.
It must be very, very frightening. Nancy, do we have any further business? I don't see any motions.
No?
Oh, my.
Closed session.
No closed session? There being no further business and no closed session, this meeting is adjourned. Thank you.